So good afternoon everybody.
दोन वाजता
एक आहे, एक आहे.
वाजले किती? सव्वा दोन. आपला अर्धा तासाचा सेशन आहे.
Good afternoon everybody. So we will start our session. So the next session is on setting up practice, and there are many things that you have to understand that once you have done urology, what would you like to do? May I call upon stage Dr. Sanjay Kulkarni sir and Sapni sir to moderate the session.
सर चालू करा.
Well, good afternoon,
चालू नाही.
and compared. Chaluka. Yeah, so this session actually is devoted because a lot of people were interested, especially the junior people, and who are just finished the residency and they are in the search of this. That's why this actually session is kept. That what are the options once you finish your urology training, whether it is residency or fellowship at this, what to do afterwards. So we have three speakers who are going to give their own perspective, and then we will have some little bit of a discussion. So first may I call Dr. Abhishek Singh to give his perspective on post-training about the fellowship options available. Abhishek, please go ahead.
A very good afternoon, respected Chairperson, West Zone Council. Thank you for this wonderful opportunity, and a shout out to my brother Abhijit. He's doing a great job hosting this conference. And today I'm going to speak upon post DNB and MCH options for training, fellowship options, how they can be applied for and achieved in our milieu. My basic disclosures are there's no central registry which tells you that these are the fellowships that are available. All the information presented is gathered by personal inquiry. The data presented is also a reflection of my personal experience and biases. Needless to say that the coaches make the beautiful arenas. There is no Sachin Tendulkar without a Ramakant Achirekar, and both of them are inseparable from Shivaji Park. This is how our life stories are. So you cannot talk about Abhishek Singh, Ravindra Sabnis, and not talk about MP. So everything goes together. You are at best the average of 5 wonderful people that you always interact with. But influencers always come in different packages. Here are two of my fellows. When I became a teacher, taught me more than what my teachers would have influenced. So this is the pattern in which we train. When it comes to subspecialty, we know that robotics and urology is a technique-based thing. Then there is reconstructive, uro-oncology, transplantation, female urology, endourology, andrology, and pediatric urology. Now let us take segment by segment. This is robotic urology. Basically, the foundation takes the lead in providing these fellowships. I have enlisted about 12 of them. The one at Kokilaben, Max Super Specialty, Medanta, Rajiv Gandhi, all the program directors are prolific teachers. Then you have one at Aster Medicity, product program director Dr. T.A. Kishore, at Asian Institute of Nephrourology at Dr. Gauss. Then at Shuri by Dr. Anant Sivaraman Krishnan, at Manipal Hospitals by Dr. Deepak Dubey, Medanta Gurgaon by Dr. Rajesh Alawat sir, and then there's another one that I mentioned by Dr. Gagan Gautam sir. Then there is Max Specialties. Saket has a different fellowship with Dr. Anand Kumar sir also. Then at Indo-American it is headed by Dr. Rakesh Sharma. There is the new one which is started at Apollo Hyderabad now, and the similar a newer one at UCG Ahmedabad, headed by Dr. Arta and Dr. Bashir. Now to get into these verticity fellowships, it is a standardized procedure. The application has to be made to Verticity Foundation, and the stipend is good. It is more than a lakh of rupees, and they will give you an option. It will be a centralized thing for all the verticity. Then you have laparoscopic fellowships. Presently, laparoscopic fellowships is a heterogeneous space. So the one, this was the flagship fellowship headed by late Dr. George P. Abraham. Still, I saw this yesterday. It is active on the website, and Dr. Jackson is heading the program at present. Patrankar sir's MUHS accredited laparoscopic fellowship at Pune is doing very, very well. And then MPUH is also in this particular space of laparoscopic training. We have a World Endourology Society recognized 2-year fellowship. And similar program is run by Anup Kumar sir at Safdarjung Hall. Coming to the space of reconstructive urology, you have an international fellowship, MUHS recognized fellowship, both at Eurocul, and the GUR fellowship you have to apply through the society itself. And the MUHS fellowship you have to apply through MUHS. Then you have a reconstructive fellowship at Varma Institute where Kore sir leads the program. And one program is also MUHS. Then I'll tell you a few uro-oncology fellowships, a 2-year fellowship at Tata Memorial. Then there is a 1.5-year fellowship with Dr. Raghunath at SCG. This is accredited to Royal College. Then you have a 2-year uro-oncology fellowship at Amrita. These are different. These are uro-oncology fellowships, not strictly robotic oncology fellowships. Then you have one with Dr. Rakesh Sharma and in Hyderabad, one at TMC Kolkata. They all have different application procedures. The one with at Indo-American is again university recognized. Then you have LGPGI and AIMS. Both have uro-oncology fellowship programs and you have to apply through their website. The LGPGI fellowship you can apply with a CV, and the AIMS fellowship you have to write an exam. SPGI also has a pediatric urology program which is headed by Dr. Ansari, and there are a bunch of other pediatric urology programs, one at Amrita, one at Apollo Chennai, one at Costa Apollo, and other than BLD Hospital also, BLD University also has a pediatric urology. Coming to transplant, a dedicated transplant fellowship is there at SGPGI, and then there are some of training fellowships. MPUH presently is also one of the centers. Then there is Medanta Medicity. Then there is Rabindranath Tagore Institute of Cardiac Sciences. Anup Kumar sir has a 1-year fellowship. Then at AIMS, apart from uro-oncology, you have reconstructive transplant fellowship. The transplant fellowship is with the Department of General Surgery and Transplantation. And the application process is that stage 1 is a written exam, then they have interviews, and then they cool down and then do a selection process. There are a few endourology dedicated fellowships that are available. One at Rainbow Hospital with Susan Agrawal as lead. Then there are a few others, like one with Dr. Devendra Sharma, the one at JJ Hospital, then you have one at which Dr. Kamlesh Maurya heads at Bilaspur, and then there is one at Mumbai. PG Hospital has a 6-month fellowship. They take 2 candidates per session. Then there is a urogynecology fellowship. Very importantly, urogynecology fellowship is there with All India Institute and KIMS. These are only 2 places which offer urogynecology training. They are basically gynac heavy departments. They are very difficult for urologists to get there. Andrology is a serious area of need. Though there are a number of listed fellowships, but one I know which surely is working is one with Dr. Anish Noor at Jyoti Hospital. He has intake of 2 per year. Then I got this list that there are a few hospitals which also offer oncology programs, but I could not get the contact of the head at this point. So I'm not sure if all of them are available at this point in time. USI has offered a new list of fellowships. So this is what has come in lately. ACE Hospital, Raghuji Hospital, Jyoti has mentioned Medanta, Artemis for a transplant with Dr. Varun Mittal. Then Aster Medicity again has a 2nd fellow opening with Dr. T.A. Kishore. And Tirthankar Hospital has a 3-monthly course at Akola with Dr. Mahabs. So this is in short about the fellowships that are available. Few lines about traveling fellowships and why they are important. So a trainee travels to different places to learn different things and gather different perspectives. So what is available presently is a World Endourology Society. They offer $5,000. The most coveted, the IAUH Equivocity Fellowship. It is also funded. Then you have a JUA Fellowship. It is also completely funded. Has a fund of about 3 lakh yen. European Society EAU Fellowship. This is a short training program, completely funded, about 3,000 euros. Then you have Young Urologist program, which is led by UA. and last year flying program. So these are the traveling fellowship options that company has. And then a brief word about international fellowships in US and UK. So basically, if you were to go to UK, get your language cleared, IELTS or OATS, and then there are two websites. One is the NHS Jobs. Through NHS Jobs or track you apply and get into the pass. If you were to go to US, then you have to do the ECFMG certification and then apply through different societies like AUA or World Endocrinology Society, and through the central lab, you get into the specialty that you desire. Important things that you learn from a fellowship is that same problems are different and can be solutions. Many applications that you you get accepted for one. Small observed details make a big impact on your practice. Learning is beyond training. Ideological change takes you a long way. Observation can make you even discoverable and there. Cultural imbibition is the key to learning in foreign environments. Apart from this, when my thoughts on fellowship. So this is something that will help you more than the slides that I gave you, because other things are available on the internet. The technology changes faster than you think. The technology-based fellowship cannot be the best thing. Concepts will remain with you. You change one set of belief with other as you progress in life. Your ability to adapt is the most important virtue that you have. Always remember, the race is always in a limiter. So soft skills will count more than the hard skills that you have. It's always good to keep your hand up, but it is even more important to deliver what you promised. Saying no politely is a critical virtue, so start. Thank you for your patience.
Thank you.
चालू है
Hello, thank you, Abhishek. Now I invite Ashwin Tamankar. Ashwin, one word about him. He is the next rising star from Pune, who is going to shine all over the country. When Sanjay Kulkarni says this, it's very important for you to understand and listen to him carefully.
That's a humbling introduction, sir. Really appreciate that. And I'm here to talk about subspecialty practice. Disclosures, leadership trained person for both robot as well as uro-oncology, not just robot. I'm vocal for local, definitely not been narcissistic here. But this talk is something that I have to showcase what we are doing in subspecialty, and that's the whole point, unfortunately. And localizing into uro-oncology, because that's my entire world. So this all started, it's very humbling to talk when Sanjay sir was moderating the session. Me, sir, and Gagan Gautam actually thought of this concept of subspecialty in the beginning. We interviewed people in one of the meetings for residents and kind of assimilated some inputs out of it. This was all with an inclination in my mind that can I not restrict to subspecialty and survive? That was a question. Of course, we had seen seniors in uro-oncology who were surviving, but still it is a difficult call when you're exiting from your residency and thinking about the same. I followed through 3 courses of fellowships, one with Gagan Gautam and then TMH for a year in uro-oncology, and then one again for robotic fellowship in UK. So 3 years of equal investment as compared to MCH or DNB program. And informations of that's for any, I don't know whether there are any trainees here, but informations are widely available. There are blogs. Authentic fellowships will give their exact logs, how many cases, exposures, everything in detail for you to go through. It's good to go back to the previous fellows who have exited. Fellows verdict is the best verdict which you can ever have for experience counting. International fellowships, as Dr. Abhishek mentioned, it gives some soft skills, makes you more refined in terms of understanding. Your professional skill sets improve. You tend to make some more international friends and colleagues, and that increases your peer circle. That's very important. And these were fantastic boxes. So UK, it's not purely onco specific, but it is organ specific. So these were 4 teachers who were teaching me for radical nephrectomies, partial nephrectomies, prostate and cystectomies. 4 different gametes and 4 different people for entire 1 year. That was a very humbling experience. So now coming to the core topic, when we talk about subspecialty practice, I remember this when I was a resident. I used to talk a lot to Dr. Abhishek. Still, I talk to him a lot for any guidance, and we always used to discuss that whenever we see the growth path, we should look into careful anatomical configuration of kind of holistic growth of all clinical surgical skills,
likewise academic and research skills as well, and that's something which is important in subspecialty. I'm going to say some clinical points. So those concepts need to be assimilated. Just 1 year of robotic fellowship may not qualify you for getting all decisions for your oncology, pit part, and quick decision makings cannot be the valid point. So that's very important. He listed out fellowships just recently, and I was amused with the amount of fellowships which we have in robotic training in India. It's almost 15 fellowship centers. That's a huge number. Probably it's more of a technology driven rather than a specialty driven thing which is happening. And of course, important is to give justice to the patient. So when you are talking about a specialty, I will probably have only 5 patients coming to my clinic every day, not more than that, out of which 2 will be new, 3 will be follow-ups. So I need to invest at least 2-3 hours to them to give justice, and that's something which is important, which I have to do. At least pre-operative an hour of counseling for the patient, and that's something which translates to patients for decision making as well. Encourage for second opinions in the beginning. That's something which is important. If you have a clinical dilemma, encourage patient to go back to some senior clinician around for an opinion. We do it very regularly, and Dinanath that is here. And vice versa. I'll give you anecdotal evidences as and when we go to the top. There is a recent patient who had been seen by a senior colleague from the same hospital. I'm not going to name the person, but came to me for an opinion, and RMO was writing a note, which the first statement which I uttered to him is, senior clinician has already seen you, he will do a better job than me in robotic prostatectomy or something. So happy for you to go back to him. I will have a word with him. So that's something which is important. Patient agreed for undergoing surgery with both of us eventually. But the resident, what I achieved out of that was the resident or the RMO, after the patient stepped out, told me, sir, there are a lot of things to learn from you. That's something which is very important. So don't be very greedy in the beginning to snatch cases from one side or the other. There are 2 team works which I would quote here. One is good clinical work, which will be decision making oriented, and that key for that is of course a multidisciplinary team approach. In majority cases should be going through this. Have a consistent team of uropathologists, uroradiologists, discuss with the radiologist. So with a process, and at least in Dinanath in the last couple of years now, the radiologist now knows what we are expecting out of it. In prostates, she gives me a phone call and tells me, Ashwin, I see planes getting lost here, there is some extra prostate extension there. I make it a point that pre-operative day I go down and sit with her for discussing about anatomy of partial vasculature, disease about prostate, capsular contact, whether to spare nerve on that side, yes or no. All these things are part and parcel of good clinical decision making. A very notorious factor in the initial part of career is peer pressure. I'm still in that phase, of course, yes. But just one inquisitive question, that if a senior clinician or a clinician has recommended a robotic surgery, just out of peer pressure, are we also going to do the same? That's something which we need to answer in our own mind before giving a plan to the patient. And that's a very tricky moment. Small 1 second of pause in a justified way in your own mind will give you that answer. Just go through these scenarios: complex hilus, complex cystic masses, large renal masses, IVC thrombus, RPLNDs, whales. If you haven't done adequate open RPLNDs, are you going to recommend robotic RPLND to a patient just because someone else has said robotic RPLND? So all these things are important in the initial phase of career, so as to avoid any mistakes. Subspecialized practice in a pure sense, prime time, probably yes, of course yes, but it's a variegated domain. I'm not here to be proponent of only subspecialty, but if you have chosen that path, then I would probably say stick to it. It's very important. Like I said, my pure entire 100% of money which comes home, a limited money which comes on, is only on your oncology. That I can proudly assure and say. So small nursing home practice, probably all of us will agree, it's probably epoch in the history now. Most likely in another 10 years time, no one would want to have their own nursing homes. I may be wrong or blunt in saying this, but that's might be a story. And last, these 2 statements are little bold statements. So, but this is just for a general thing for young urologists. It's very difficult to be clones of our gurus now. That's a very important statement which I'm making here. We follow their philosophy. We take that forward. We have Desai sir, Kulkarni sir. So we can't be imagining ourselves to become Dr. Yuvaraja in my field. I can't imagine myself to be the second Yuvaraja. You don't have to do that. That's a basic understanding. Why I'm saying this is a young urologist who is going into a robotic fellowship. I get a lot of phone calls from them. I have a blog on Vatikiti website as well as RPS website. They tend to call and ask, sir, we are fascinated with what Dr. Yuvaraja does. So first statement which I caution them is, don't just enter into a fellowship just because of that. If you have conviction, go into a proper specialized training. So that's something which is important, and we need to have self-realization of that. So that's very important, and focus on your self-honesty. This is about the clinical decision making. Now coming to the surgical bits, it's a steep learning curve for all of us. Shrenik sir was mentioning about complications. So all of us have to go through that phase of evolution of the path, and we know all these four terminologies. I'm not going to go in details of it, but it's important to learn from mistakes of yours, mistakes from someone else. Dr. Sir is here. We were together for a difficult partial effectomy, complex hilar mass. We tried to win our battle, resected the tumor completely. Unfortunately, in the renography, the bleeding was quite high. It was probably hilar mass. We took almost 12 sutures on the renal vein completely as and when we crossed through the enucleation side from the hilum. In the end, I kind of chickened out because post unclamping, the bleeding was quite long. Probably Sir's temperament at that point of time was just to hang in there for a little more time. I being little premature, I converted to that radical mastectomy. But the next day I went back to him and asked, so I had some little more patience and tried converting to open or tried to stick to still partial effectomy rather than converting to radical, because the frozen or the final path of partial effectomy patient was negative for March. So we had achieved what we did for tumor, but we couldn't survive the kidney. That was a very sad affair. So these are important points to go back to senior clinicians and discuss to learn. That's something. And a point which he drove across to me was you should have continued enucleation on the lateral side as well, which you started off near the hilum. Because I took parenchyma on the lateral side, which is opposite to the hilum, that started oozing a lot, and I couldn't control that bleeding to a large extent. So these are important points. So surgically, I said about clinical team. Now this is surgical team. Surgical team wise, we have consistent team, bedside assistant, anesthetist, technician in the OT is also something which is very important. The size are like there are people who are working with him for almost 30, 40 years, if I'm not wrong. So these are important things for patient safety. That's something which is very, very important. Self-realization about this learning curve, limitations, and call for collaborations. These are very important. It's a thing in verbal story that one bad story will kill the whole experience. So जो booth से जाती है वो hot से नहीं आती. That's I think the Hindi nomenclature for it. So learning curves are steep. I did an analysis of robotic learning curve for prostate, and there it's about nearly 300 cases. It takes 5 to 6 years to overcome that as an independent surgeon, and that was acknowledged by Professor Tony Costello by himself after reading through the article, and that came as a compliment on the email, and I was very happy about that. Professional mentor is something which is important, who will vouch for you, who will stay with you. You can go back and discuss with him all the negatives in a confidential way. That's something which is very important. And like I said, it's a holistic approach. You don't just look at the case or the operative. I also need to look into counseling of the family to educate the son of the patient for undergoing PSA testing, getting the genetic testing done for patients of prostate as well, and then only once you start doing it, you'll find some positives. That's my anesthetist father actually, liver transplant anesthetist father whom we operated, and it turned out to be positive in an early disease. So that's something which is very important. Peer recognition, so we spoke about peer pressure. Now this is peer recognition, which is an equally important bit. Because of want of time, I'll rush into it quickly, but it's not something which you need to be soliciting for. It's something which is an automatic process, and it has to be correlated with your behavior and research. Talking about research, I'm skipping this. Just quick things which I can say is, in your fellowship, if you want to be actually producing it productively, it's not just the surgical skill, but the whole gamut of academic and research work, which should translate from presenting to publishing as well. These are very important domains. I'm skipping this for the want of time. That's one important thing which I can just quickly vouch is we analyze. So information is available. It's up to our hunger. How do we want to take it forward? So this was the data of 500,000 prostate biopsies in UK NHS for presentation. When it came to me, I was puzzled, how am I going to settle this for 500,000 biopsies? But when I actually went through this, it was an easy go because it had segregated between transperial and transseptal, and we published that was cited in my name in European Association of Urology guidelines, which is probably a lifetime achievement I can consider for myself. So these are stuffs which we need to be aware of. I'm skipping this. We have a lot of opportunities for publishing, writing papers, writing book chapters, and I think so. That's the last slide. With this, I would end. I would also put a quick first invitation for all of you for a meeting which we are organizing at Dinanath in challenging case scenarios in uro-oncology. It's a little different kind of meeting which we're planning to have. It's on 22nd and 23rd of August, a couple of months from now, and I'll end this. Thank you.
Thank you, Ashwin. We now go next to Dr. Ashish Jasani, who is going to tell about the general urology practice, whether a person should stick to general urology.
After hearing his talk, I feel like a dinosaur. Talking about general urology in the era of 2025, where there are Abhishek, you said what 200 some specialty centers and places. So my talk is a debate, right? So there will be some biases, there will be some anecdotes. Kindly apologize. I take that and start my talk, sir. So let me start by saying that okay, we have a nice heavy workload for 1 week, and in the weekend I told my wife that we cook a dinner. She was smart enough. She told me to go and buy the groceries. So I went to the market. I went to the first stop to get some veggies. So I said, okay, I need some okra. So she said, yes. And I need some spice, I need some chili. She said, no, you have to go to the next shop. So, sorry. So, okay, I said, I need some, so he tells me, you need katta also. I said, I need some lemon. He said, no, you have to go to the next shop. Okay, so along with the vegetables, I need some chapati. You have to go to the next shop. At the end of the day, I was so frustrated that I went back to my house and told my wife, let us children go to sleep. This is some specialty. This is what I want to bring it. Mine is more of a spiritual talk rather than a very theory-based talk. End of the day, patient doesn't know. He comes to you for a urology complaint. You tell him, no, you have to go to uro-oncology, you have to go to pediatric, you have to go to uro-oncology, you have to go to endocrinology. End of the day, you need to treat the patient. And that is where I start my talk. So, what is the training structure for any urologist, right? It is 4 years of medical school, 3 years of general surgery, and 2 to 3 years of urology residence. And I think all the youngsters would know about the SMART protocol of goal setting. So it should be specific, measurable, attainable, relevant, and time. So what does he think when he comes out? Okay, now I want to go into uro-oncology. It's measurable, yes. 1 or 2 years I should be able to manage it. Is it attainable? I think I have the skills to do it. And is it relevant? Yes, very relevant in today's time. Yes. And is it timely? Yeah. I just pass up the right time to do it. But the reality is something else. What happens actually when you leave an institute? There is a lot of theory in your hand. Very limited hands-on work. See the number of seats in urology now. When a resident comes out, how much work can be done? No experience of handling or owning responsibility of a patient. This is very important. There was always a senior or teacher above him. And there is lack of expertise in dealing with the patients and relatives individually versus an institute. Now, the ground reality is something very different. There is a very high output of urologists across the country. Very limited places to work. I think when I passed out of urology, there were 5 seats in Gujarat and maybe total 40 seats in the entire country. Today, how many seats are there? There are no places for urologists to work. Ask the junior. First the corporate fill up, then the semi-corporate fill up, then the pseudo-corporate fill up, then the trust fill up. And there is no place for them to work. So what happens? Roaming and yojana practice has become the new norm now. One cannot be choosy about the type cases to perform and those available to him. In desperation, they create a niche for himself. Fresh path out, rushes into subspecialty. So I call them super subs. So are these super subspecialty ready and possible for them to survive? What is the recommendation? The recommendation is very clear. It is not just customary, but practically essential to build solid grounding in general urology before you narrow your focus to any subspecialty. How and why? That's what we'll see. First is comprehensive understanding. So I am talking about practice, I am not talking about residency. Breadth of cases. General urology exposes you to the full spectrum of say UTIs, BPH, stones, cancers, incontinence, trauma, whatnot, and many more. So as you start practice, you start learning those patterns and pitfalls as a general urologist. Core techniques. So from cystoscopy to transurethral resection to laparoscopic kidney to reconstruction. As one operates, he or she acquires the manual dexterity and decision-making skills that are very important. And finally, the diagnostic equipment, understanding imaging, urodynamics, PSA kinetics, complex patient workups in a general setting hones your clinical judgment before you encounter the highly specialized diagnostic of say a neuroradiologist or neurology. What else does it offer? Encompassing care. By that you mean you learn to coordinate with nephrology, with gynec, with onco, with radiology, the general urology setup, which is crucial when you need to navigate multidisciplinary tumor boards or transplant teams later on in life. These are all skills that you need to learn before you rush into something. And then comes the question of resource management. So managing a general urology practice teaches you triage. I don't mean triage like an emergency. Who needs surgery, when to wait, when to refer, and most important, whom to reject. I think everybody has learned that. It takes 3 years to learn how to operate, 10 years to learn when to operate, a lifetime to learn when not to operate. This is triage that you learn while doing this general urology practice. This skill is invaluable. Final thing is adaptability. What is it? It equips an individual who is seeing everything together to the changing patient needs and emerging technologies. Career flexibility. So I am little biased towards service. So my first point was in many regions, especially rural and smaller cities, general urology services are not available and to remain in demand. Having broader urology skills of general urology means you can serve more where you are most needed. And hybrid practices. Does a subspecialty only be able to survive only in that specialty? Probably no. He'll also be doing some cases like a prostate cancer surgeon who will be fielding cases of BPH and stones and other. He was talking about articles. I saw a lot of articles actually. I'm just quoting 4. While searching for presentation, I could see the first article written by Professor Frank Inman, and this was in 1989. See the vision of that man. I had not even done my MBBS then. I was my MBBS where he has written an article of subspecialty. Urology subspecialty. This is an article which is 37 years old. You see articles beyond that from Dr. Das Gupta, which talks about present training. We have his article that we just quoted and so on. And a recent article from Australia. What all these articles tell us is that you need a sound base in general urology before you venture into a subspecialty. And this is my very important message to all the youngsters sitting here. I'll just put an anecdote. Imagine what will happen if you restrict Tendulkar to playing only the covered role. Or if you restrict Dravid to playing only the forward stroke. Or Ganguly only hitting the pulls. Shot will be excellent. The game of cricket won't be lost. This is what I say. Next is the problem of ultrafocus. We have all finished MBBS and moved on to urology. How much of medicine, gynec, ortho do we remember? Does it matter? No, we are not going to practice that. But in a single field specialty, it does not work. Even at the level of diagnosis and decision making, areas of other urology areas overlap. So we've been doing uro-oncology for 10 years. Suppose I still remember Dr. Mulaukar had put up a case yesterday where there are a lot of stones in the kidney and there is an adrenal tumor along with. We have been doing only endocrinology for 10 years. And suppose you get a case like that tomorrow. It is at the level of diagnosis and decision making where you make a mistake. That is where comprehensive urology matters. What will happen in the future? You will have a pediatric uro-oncology. You will have a separate male and female endocrinologist. You will have a separate upper, middle and lower tract reconstructive surgeon. And still further, what will ultimately progress to sub-specialist? He will be an upper caling specialist, he will be a middle caling specialist, and he will be a lower caling specialist. How dare you touch my case? So, finally is the point of repetitive boredom. I wanted to make this presentation interesting because it's about general urology. Imagine meeting only a general uro-oncology colleague for the rest of your life in your subspecialty meeting. You will miss out on the wonderful advances in the other areas of urology. What will happen is, because of this repetitive boredom, there is a chance of early burnout. This is now doing something serious. Doing only one type of repetitive cases is not good for all of us. Then you'll end up with stagnation depression. So, what does a fresh urologist need today? Gradually ease into a work pattern starting from simpler to more difficult cases. Learn from the field experience of our senior and colleagues sitting here. Build a base of comprehensive expertise in all the areas of GU system, all kinds of pathologies, all ages and both sexes. Make your own mistakes. Learn from them. And do it in simpler cases rather than very complex specialty cases. And best of both worlds. How do you now? You can't just do general neurology. What I'm talking is all outdated, right? No. While you are doing your residency, what should you do? Targeted rotations and research. During residency, you should seek out electives, research projects, or junior call weeks into subspecialties you are passionate. You get a taste of it while you are doing general urology. Cultivate relationship with mentors. Even though your day-to-day is general, you learn procedural and emerging technology. It's a short presentation, my last slide. Let me tell you that all are not made up for this kind of ultra niche, ultra focused area. Practice a good 2-3 years of general urology. Gradually understand your interests, your strengths and weaknesses, opportunities available, and definitely go for a specialty if you feel you are made for it. Right? That is my presentation. Thank you.
Thank you, Ashish. I will just tell you a short story. We get 2 American fellows every year for GORS fellowship, and we have to interview about 30. There was one who I asked him, "What have you done?" He has done, "I have done fellowship in robotic surgery, urology in America. Now I'm applying for the GORS fellowship." I said, "Why you want second fellowship?" He said, "Every American urologist is a robotic urologist. It's no more a specialty." So one day, now 15 centers in India, more than 100 robots in the country, robotic surgery will no more be a subspecialty.
Yeah, Shrenik, you want to say something?
So luckily the experience was good. First was with Gagan Gautam sir. I was a first fellow with him, so it was new for him as well. And these are his own words that a fellow
Ashwin, speak slowly.
Yeah. So teacher.
Like Margaret Thatcher.
Okay. Sir.
Very slow.
So teacher, basically the mentor also learns from what you are giving it to the fellow. So that was a good experience for both of us. About 106 cases in the first block. It was pure robotic fellowship because his majority numbers, 95% are robotic.
How much you know?
Every case about 45 minutes on console. So approximately calculated, and about 5 to 6 complete procedures by the end of the procedure. That was a very early times of Vattikuti. UK fellowship was about 40 odd cases completely independently and about 180 cases in the log for 1 year. So that was a wholesome experience. TMH was more into open because at that time my bosses were themselves in learning curve of robot. So it's a good experience everywhere and that translates. But not every fellowship, not every fellowship translates this.
Now, I want to ask Ashwin one question.
Yes, sir.
That you have now restricted yourself only to oncology.
Yes, sir.
Do you often feel or sometimes feel that you are missing lots of other things which actually you were liking before or whatever reason?
Probably not.
Because that is what actually comes into the mind, and when we took an interview of a lot of people,
Yes, sir.
they said, "No, I want to actually pursue some subspecialty, but I also don't want to sacrifice and forego all other things."
Absolutely.
And that is where the dilemma comes in, and that is what is the mindset which everybody has to eventually decide what they want to do it.
I think that urology, if I tell you my story, when I did my MS, I did my, I did my general surgery and went to England, and then I liked the urology, I took the urology. And the urology, only endoscopic thing we were doing was the cystoscopy. That's it. So, that's a specialty from general surgery. After some time, endourology came, stone came, PCNL, ureteroscopy, ESWL came. But then we started doing transplant. And all donors were female, nearly 70%. And we are doing such thing. And then Dr. Gill came and he showed the laparoscopy. And we learned the laparoscopy. Then we for 3-4 years we were learning, and then we sent here one of our residents to learn laparoscopy. He went to Cleveland and he learned laparoscopy, came back and he taught us, and then we started doing laparoscopy. After next visit he came, Now I think the robot is the main thing. Future is robot. And then he taught us the robot, and then we bought a robot, and then after that, sir, so many things. He says robotic flexible ureteroscopy. We did that. Then we did a tuna. We did a, we become specialized every day, So I think the whole thing is evolving. Today, what we feel become a specialist, tomorrow we would be general. Because then he says he does all prostate cancer. But now the micro ultrasound has come and we are diagnosing tumor as small as this. In the targeted therapy, operation is gone. So then you become I think what you said, okay, we have to keep our mind open and go on learning. Then for that period, specialize. And one day I was sitting with Mihir and my grandson, and then grandson said, Dada, did my father taught you laparoscopy and robot? I said, yes. Did he operate on you? I had a kidney tumor. My son did a robotic partial nephrectomy. Yes. When I grow up, I will teach my father. So I think what is important is to learn. Science is progressing, and then even you do something and don't stop it. I think you learn and learn and learn, and then become a more beneficial to your patient. What is your patient needs? And I think this is a very good debate we had. But I think we have to keep our mind open and try to see what is new coming. Because the human mind is such that it innovates. And that innovation must come. For the young, I think I see so many young people. He was my student. But today I saw his talk twice, and he is beautiful. I mean, I don't think I ever taught you how to give a talk.
So I think only one point.
One word. In England today, there are lots of hospitals who have 10, 20, 30 urologists. So there is hardly a general urologist. Give an example, Dr. Deepak Kripekar's son-in-law, my student, Prasad Patki, does upper tracts robotic surgery. It doesn't do prostates. So this is what we will come to. And we have to be, so if you go to a small town, individual practice, general urology is fine. If you want to join a group, a corporate hospital, they will ask you, what's your specialty?
So the takeover young residents are just also that the sub-specialization is contextualized to the situation you are in and curve of growth in your region or your country. That should be the key. They should watch for what's happening in and around, and then sub-specialization is contextualized. Like you say, the can upper tract surgeon, which is a fact in the West. No, somebody does prostate doesn't do. It is very, very clear. So, in our part of the world, what is going on, your sub-specialization can be contextualized. When Umar Isa started doing stone in PCNL, he was sub-specialized. So that it is a contextualization to what situation you are.
So it all depends upon where you want to go and practice and what is the situation in that city, in the hospital. Suppose you are in a small town, you are a single urologist, you have to do everything. And even in a large setup, everybody could do some endourology as a part of on-call, and you could sub-specialize. That's the best way.
Yes. So if I do oncology, sir, and I say where I don't have an interventional radiologist and I'm not going to birth, that doesn't make sense.
So the only thing I think the youngsters should get a message is that you don't vouch into subspecialty very fast. You give it a time, you understand yourself which suits you. It is not just what is going in the market, you go by it, but it is finally what you like the most, then you choose the subspecialty.
I think the point that the youngsters need to take home is because design where they are going to settle.
Yes,
They are
exactly.
going to settle down the years again is different. They are going to institute headquarters.
See, there is one more point. In individual practice, it is impossible to survive only on subspecialty. It is a fact. Though
Thank you for it. Now I just understood whether subspecialization to be done or not. Now I have.
See, not only that, you should know what you are good at. Not we can do everything. Like all my hypospadias, they used to leak like anything. All fistulas, 100% fistula. So I recognize that this is not my cup of tea. So this is how we learn what I am good at, and once you know what you are good at, project that and do that. Your mental satisfaction will be there.
So now once I've done my urology, what should I do? Okay.